I've finished vital signs. Now I'll move into an assessment of head and hair. I'm going to look at Steve's hair, make sure there's no thinness or loss or any abnormalities of the hair, and the scalp. I'm palpating or checking for any lumps, or if a patient had tenderness of his scalp, to find the area of the tenderness there too. I see no abnormalities, so I'll move into eye. The next part of the exam is the eye exam. And with all exams, of course, you're going to start with inspection. With inspection of the eye, you look first top to bottom. Start with the eyebrows, eyelids. Look where the lacrimal glands are. Look at the sclera and conjunctiva and the pupils. And always, of course, comparing one eye to the other. Now, the next part of this is I want you to look up towards the ceiling, and I'm going to just pull down the lids here. I'm looking at the lower part of the lids. All right, good. And again, comparing sides there. The next part is visual acuity, when I'm going to assess Frank's vision. Now, in your clinical practice, you'll often see your preceptors checking with an eye chart that's 20 feet away. I'm checking near vision, and that'll be about 14 inches away. And for anybody who needs reading glasses, they should put those reading glasses on. So Frank, you can put your reading glasses on, because with near vision, he will not be able to see if he needs reading glasses. Now, Frank, can you hold this about 14 inches away? Now cover up your left eye, because I'm going to be checking one eye at a time. And with Frank, with your right eye exposed, look at the lowest line of numbers that you can read there along the left side of the chart.
937,826.
All right, and so when I look at that, that is 20/25 vision with the right eye. Now if you can cover your right eye, now I'll do the same thing with the left eye and check your vision again on the left eye.
937,826.
All right, and same thing, so 20/25 vision on both sides. And what I'll do now is assess visual fields. Now you think about the visual fields as in 4 separate quadrants. There's a upper quadrant, temporal quadrant, lower temporal quadrant, upper nasal, and lower nasal quadrant. That's for each eye. So I'm going to check each of those quadrants. I'm going to use fingers. I'm going to ask Frank to tell me whether he's seeing 1, 2, or 5 fingers. I'm using those numbers of fingers because it's easy to distinguish 1 and 2 and 5 from other digits. So Frank, if you can cover your left eye with your left hand, and what I'm going to do while he's doing that is I'm covering my right eye so that I can check my field of vision against his as a standard. Now you look at my nose and then tell me how many fingers you see me holding up. And
1.
Yes, and just watch my nose if you can. Okay, now tell me how many fingers?
2.
All right, and how many fingers here?
5.
And you see that I'm holding it in a way that he's able to see how many fingers. I'm not going to turn my hand in different directions where numbers of fingers can be confused. Now we'll check the same thing with the other. Keep your hand there. And how many fingers do you see here?
2.
And how many fingers here?
2.
All right, now you saw that he didn't see the right number of fingers in the upper outer quadrant, so I'm going to check that again. Now tell me again how many fingers you're seeing here.
2.
All right, so I've checked all 4 quadrants of the right eye. Now you can replace that hand and now cover up your right eye. Now we'll check the left eye. We'll do the same thing, starting first with the upper and lower outer quadrants and then switching to the inner higher and lower quadrants. All right, so again, tell me how many fingers?
5.
And how many fingers?
1.
All right, and here?
2.
And here?
1.
All right, good. So he's checked all those quadrants on both sides. Now the next part of the check here is to check for the near response. I want to see that as Frank looks in the distance and then brings his eyes in and looking towards me, his eyes converge a little, come in closer together, and there's a little bit of pupillary restriction, but I may not be able to see that. Now Frank, if you can look at the wall over there, okay. And now look at my finger here. And what I see is that his eyes converge and come together. I see a little bit of pupillary restriction. Now I'll move right into checking extraocular motions. Just watch my finger here. And I'm going to move this in an H pattern. Out this way and up this way. I'm watching both eyes, making sure that they're both moving in conjunction with each other, and out this way up the H pattern up to the top and then down to the bottom. Okay, and then back to the center. So that checks all the extraocular motions of many of the different eye muscles. And the next part that I'm going to check is watch for pupils to see that they react to light. Now typically for checking pupils, you want to turn off the light. I'm going to leave the light on so you can see what it is that I'm doing. But as you're examining patients' eyes, especially the pupils, or looking at the retina, you would turn the light off. So I'm going to bring over the ophthalmoscope, and I'm going to show you a few aspects of this ophthalmoscope so you can see what are the characteristics here. First, this is the back of the ophthalmoscope. This top part, you would rest right on your forehead. And this is what you would look through, this aperture here. And right down on the bottom are a set of numbers. And that number you should always have set at 0. This dial on the side is how you would turn that number away from 0, but you're going to keep it always on 0 here. Now I'll turn the ophthalmoscope around the other way. This is the patient side to show you some of what you see here. There's one dial here that'll control the light characteristics. And then there's another dial here that controls how bright the light is. So I'll show you how that works. I'll use Frank's gown here. First, the brightness. This is this dial here. As you watch that light, you see that it's getting brighter and dimmer as I'm moving this around. And when you're examining someone's eye, when you're looking in the back of their eye, you want to leave that light source about in the middle, not super bright, not dim. And then the other dial that I showed you for the source of the light, you can move that back and forth to see first a small amount of light, medium amount of light, large amount of light, and then you go to some other aspects that we don't use in PDS. One is a target, a slit light, and then a blue light. But what you want to use for the light source is about the medium size. So medium size light source, about medium intensity of light here. Now what I'm going to check first is Frank's pupillary response. And as I said, I would typically dim the lights here, but I'll keep them bright. So if you can look against the opposite wall here, what I'm doing is I'm shining the light in one eye here to see that the pupil is constricting. And while this pupil, the right pupil, is constricting, the other one should also be constricting. And then I'll go over and check the left pupil and see that the left pupil is constricting at the same time that the right pupil is constricting. That's normal for both pupils to constrict, even though light is shining just in one pupil. Now the other part of this is the swinging flashlight test, or checking to make sure that pupils stay constricted. So I shine on this eye, and then I move over here for a couple of seconds, and back over here. I'm looking at both pupils as I'm doing that to see that both pupils are staying constricted as I move the light back and forth, as a way to check that the eyes are both getting the same information from the optic nerve. Now the next part of this is also to check the optic disc. The main purpose of checking the optic disc is to be able to see the end of the optic nerve and to see the disc itself. The remainder of the retina is made up of blood vessels and the background of the retina. In PDS, it may be hard for you to identify the optic disc, and so what I want you to be able to do in your first year and into your second year is to be able to identify a blood vessel. And as you get more comfortable with evaluating blood vessels, then you want to be able to focus in and find the optic disc. So I'll show you how I would recommend that you do this. First, if I'm examining Frank's right eye first, I'm going to hold the ophthalmoscope in my right hand. I'm going to use my right eye, and my left hand will be to stabilize myself with my hand on Frank's forehead so that I can tell how far away I am from Frank's eye. Because I need to get fairly close with this ophthalmoscope, and I need to have some sign to myself of where I am in space. So what I'll do first is I'll put my hand on your forehead, Frank, here, and I'm going to hold this over my right eye, and I'm looking at Frank's eye, and what I'm seeing here is a red reflex as I'm starting about this far away. I'm a little bit off center here, looking in Frank's eye, and then I'm going to come in closer here. And as I come in closer, I'm looking for a blood vessel. That's a red line across a palish or orangish field. And as I find one of those blood vessels, you see I focus in and I see it right about at this distance. So you can see about how far away away I am for Frank's eye, that'll vary a little bit depending on your vision and the patient's vision as to how close you need to get. And then once I find the blood vessel, then I follow it, and I follow it to a yellowish disc, which is the optic disc. As I said, that's a more advanced skill. If you find a blood vessel right away, see if you can follow it to the center and see an optic disc. Now, I'll move to the other eye. So what I'm going to do is I'm going to bring this behind the patient. I'm going to now hold this in my left hand. I'm going to look at Frank's left eye, and I'm using my left eye. And then I'll use my right hand to stabilize on his forehead. So I'll come in through this direction, again identifying the red reflex, and then coming in closer. And I see blood vessels, and then I can move in again to the optic disc. And that concludes the eye exam today. We will now move on to the ear exam. First, with the ear exam is always inspection, looking at the ear itself, and also folding the ear forward and looking behind to make sure there are no abnormalities behind the ear. And I would do the same thing on the other side also, checking the ear on the other side. Again, looking around the ear, looking at the soft cartilage and the lower part of the ear, the earlobe, and then again looking back behind the ear to make sure there are no abnormalities. The top of the ear is a common place for men to develop skin cancer because that part is exposed to the sun quite a bit. So making sure to look around the ear is important. After inspection, then you want to move on to assessing auditory acuity. Steve, can you block your left ear with your hand? Now I'm going to say a word in your right ear, and I want you to tell me what it is. Cupcake.
Cupcake.
It's important to use a two-syllable word where each syllable is about equally weighted. Now, an alternative way to do this, can you block your left ear again, is you can rub your fingers together, you can click your fingers. There's different ways that you can do this. The standard that we teach in PDS is to use the two-syllable word. Now I'll move to the other side, and you can block your right ear. And I'll say a word again here too. Cowboy.
Cowboy.
All right, great. So normal hearing on both sides. Now the next part I'll move to is looking inside the ear. And I'll use the otoscope, which has the same adjustment that the ophthalmoscope does in terms of brightness and dimness of light. When I'm looking in the ear or in the mouth, I will always want to keep the light as bright as possible because there's no need to dim the lights in any of these cases. Now back on the wall will be a speculum. This is so that you're not putting this end of the otoscope in each patient's ear. This allows you to move with this otoscope from one person to the other. What you do is you place the speculum on top of the otoscope and turn it in a clockwise direction. It clicks in a little bit, and then you know you have it in the right place. And then what I will do, now Steve, if you can turn your head that way, I will pull back on the ear like this, and this straightens out the ear canal. Then I will take the otoscope and place it inside the ear canal, and I'll look in. What I'm looking for is eardrum and the ear bones, and I'll look for all of that. I'll move the scope around a little bit if needed. And you want to be careful about this and ask your patient if there's any soreness, because if I'm pushing up against the ear canal with the speculum, it can be somewhat uncomfortable. But I'll approach that and then bring the speculum back out. And then I'll go over to the other side, again bringing the cord behind the patient. And I'll again pull back on the ear to straighten the canal, insert the speculum, and again looking for the ossicles and the eardrum towards the back. Now, if you're checking a small kid's ear canal, kids, of course, don't want their ears looked at. So you can use your hand to steady your scope against the patient's cheek. Steady the scope against the patient's cheek, and then look in this direction too. So what I have is more control. So if Steve moves his head, then the scope is going to move with him as he's moving his head. All right, then I'll take that back out again. So either way works depending on whether you have a patient who's cooperative or one who is not. All right. Now we'll move on to the exam of the nose and the sinuses. So first, I'm going to take a look at Steve's nose. And can you tilt your head up just a little bit? I'm looking at the area of the nose and around in the nostrils, again looking for symmetry, seeing if there's any skin lesions or lesions that are easily seen on the outside of the nose. Then I'm going to go to the inside of the nose, and I'll use the otoscope again. And I'll use the otoscope with the light turned up as bright as it will go to help to illuminate anything that's within the nose. I'll also place the speculum on the top, and I'll turn it in a clockwise direction until it clicks into place. And then what I'll do is, can you look up towards the ceiling? I'll place my hand, just tilt up on the nostril or the end of the nose just a little bit and look inside here. I can see what the mucosa looks like, and I can also see a little bit of the turbinates. The main way that this helps me is if somebody has upper respiratory infection and congestion, I can see if there's any changes within the mucosa that might indicate sinus infection versus other infections. Now I'll bring this over to the other side, and I'll look in Steve's left nostril. I'll again kind of stand off to the side again here, lifting up the end of the nose and then looking inside. And I'm careful to stay away from the septum of the nose, which is the most tender portion. Now, once I've completed that part, then I'll check sinuses. I'll check here frontal sinuses. I'll put my fingers right up in this area. And Steve, is there any tenderness as I'm pressing there?
No.
All right. And I'll also check here where the maxillary sinuses are. See if there's any tenderness as I'm pressing in these areas.
Nope.
And that would check for sinus infections in either the frontal or maxillary sinuses. The next part is the examination of the mouth, starting with the outside and working in. So first I'll look at lips. Lips and upper part of the area around that is an area where skin cancer can develop, so I'm looking very carefully for any new skin lesions and looking for moisture of the lips and any changes in the skin of the lips. I'll use the otoscope, and I'll turn the light up to the brightest level that it goes to look in the mouth. And the other piece of equipment that I will use here is a tongue depressor. This is a sterile package, and I'll take the tongue depressor out. I'm holding at one end, and I'll always use the other end to examine the patient's mouth. So Steve, could you open your mouth for me? Now, can you say ah? All right. And what I'm watching as he's saying ah is to make sure the soft palate rises equally on both sides. If I can't see that with no tongue depressor, then I can do this. Can you say ah? And I'm pressing down on the tongue with the tongue depressor. And if I see the soft palate rise equally on both sides, that's checking for a couple of the cranial nerves, which we'll discuss in a moment. Now, can you stick your tongue out at me? Move it from side to side. All right, yeah, I can see that he's got good tongue motion, and that's checking for another of the cranial nerves. Now, stick your tongue out again, and what I'll do is I'll move the side of the mouth to the side a little bit here so I can see on the buccal mucosa of that side, and do the same thing here, and buccal mucosa on that side, and also looking at the sides of the tongue too for any lesions as well. The other thing you can note with the mouth is moisture. Is this patient properly hydrated, and is his mouth moist as a basis of good hydration? So now I'll move into checking cranial nerves, and I'll name the number of the nerve and also the name of it and what functions we've checked for. So first cranial nerve is number 1, olfactory. There's no very easy way to check that, so I will ask the patient regarding a sense of taste and smell. Have you noticed any change in scent, in your sense of smell or taste?
No.
All right, so that's a good rough estimate that he has normal olfactory function, because if a patient loses sense of smell, they will lose sense of taste with that. The second cranial nerve is the optic nerve, and this we checked with both visual acuity, checking Steve's eyes each independently, and also visual fields. And we saw that both of those were normal, therefore cranial nerve 2 is functioning normally. Cranial nerve 3 checks not only for pupillary response, also lid lag to make sure that his eyelids open up equally on both sides, and also part of the movements of the eye. And that we checked earlier with the H pattern. Cranial nerves 4 and 6 also check extraocular motions, and we checked those earlier as well. Cranial nerve 5 is the trigeminal nerve. Trigeminal nerve has a muscular component and a sensory component. Now the muscular component is the muscles of mastication. So can you clench your jaw together? And I'm checking these muscles right here to make sure they're equally strong on both sides. Okay, you can relax. Then the sensory component of of the trigeminal nerve has 3 branches. There's a branch up in the top, on the forehead, on the cheeks, and down on the chin. So Steve, if you can close your eyes, and you tell me if this feels about the same on both sides.
Mm-hmm.
All right, the 2 branches of the first part of the nerve. And how about this?
Yes.
All right, and how about here?
Yes.
All right, so checking all 3 areas of the trigeminal nerve. So that's cranial nerve 5. Then cranial nerve 7 is the facial nerve. And the facial nerve, the parts that we can test are strength of the face or the muscles of the face. My first one is just observation. Do both sides of his face look symmetrical? If there's no droop on one side compared to the other is what I'm looking for. Then I will test different components moving from top to bottom in terms of strength of those muscles. Now can you look up towards the ceiling? You notice his forehead wrinkles equally on both sides. All right, you can relax that. Now can you close your eyes tightly and don't let me open them? All right, that checks those lids to make sure they're fine. Now can you puff out your cheeks? All right, make sure these muscles are okay. Can you show me your teeth? All right, and I see that he can bring his muscles of his facial muscles out to the side equally on both sides. Now I'll move into cranial nerve 8 is hearing, the acoustic nerve, and we checked that earlier. Cranial nerve 9 and 10, glossopharyngeal and vagus nerve, we checked by making sure that his palate raised equally on both sides as we're looking in the back of his throat. So cranial nerve 11, the accessory nerve, is checking 2 separate functions. One is elevating his shoulders. Can you raise your shoulders? I'm going to press down firmly to see that he can shrug his shoulders fairly well. The other, checking more of the neck muscles. Can you turn your head to the left? Now try to straighten. And I'm pressing against his chin as he's trying to straighten his head. Now turn to the right and try to straighten again. All right, checking those neck muscles. Then cranial nerve 12 is the hypoglossal, and this checks to make sure that he can move his tongue from side to side, which we saw earlier during the mouth exam. So that's the check of all of the cranial nerves between what we've done with the head and neck exam and then these extra tests to make sure we've checked the other ones that are not routinely looked at through the rest of the exam. The next part of the exam is the neck exam and also the axilla exam. So I'll first start by looking at Steve's neck. Steve, can I lower the gown a little bit?
Certainly.
All right. So if I had a female patient, I might have her hold the gown here so it doesn't slip down. So yes, if you can hold it there, that'd be great. I can tie a little bit of this towards the back also to make sure that it doesn't slip off. Now I'm looking at neck, looking for any lumps, and again asymmetry and any changes in the skin from one side to another. Now I'm going to ask Steve, I'm going to check the range of motion of Steve's neck. Can you bend your head forward and touch your chin to your chest? All right, and look all the way back up if you can. All right, now look all the way to the left or to the right and then turn to the left. All right, and there I had, I'll tie this gown a little bit better so it doesn't slip off. And now can you take your head and touch your left shoulder and then touch your right shoulder. All right, so I've checked all of those motions of the neck. Now I'm going to check for lymph nodes. Now you can check either from the front or the back. I'm going to come around to the back so that you can see what I'm doing. Starting first with the posterior cervical chain on the back, and I'm taking my hand and running it along the edges of the muscles to feel if there are any lumps on either the left or the right side. And you can check both sides at the same time. Moving my hands forward, checking along the front part, check in front of the ear, just under the chin, going all the way to the front. So essentially what you're doing is you've covered most of the neck in palpation to find whether there's any lymph nodes. An area for checking also is in the supraclavicular fossae. Can you rest your hands on your hips? And you see how Steve is hunching his shoulders forward, hunch his shoulders forward, and then I can check in that fossa or that little area of depression on both sides to make sure there are no lymph nodes present in that area as well. All right, you can relax your arms. Now, if you are examining the patient's lymph nodes in the front, you're now moving to the back to complete the thyroid exam. And you also want to warn the patient that you're going to be placing your hands on their neck from the back so he knows what's going to be happening next. I'm going to move behind you and check your thyroid gland, which is right in the front. So my hands will be around your neck here.
Okay.
And what I will do is I'll first take my 2 index fingers and place them right on the thyroid cartilage. Then I will move a little inferior to that There's the cricoid cartilage. Again, a little prominence there. Then I'll move my hands down a little and just to the side of the trachea. So your hand should be right about in this location of the neck. And at this point, you can use 2 fingers on each side. What you can do with the right hand is press the trachea a little bit off to the left, and you can run your fingers up and down on the left side here. You can sometimes feel some lumpiness, though it's very common not to find anything because the thyroid gland is very small. Then I can depress the trachea to the right, take my right hand, and again run that up and down the edges of the trachea on that side. Now another part of this exam is I can have the patient, Steve will take a little drink of water and hold that in his mouth, and I'll make sure my hand is in that same place, and as he swallows I'm going to be able to feel the gland move up and down underneath my fingers. So can you swallow? And as he's swallowing, I'm feeling if there's any changes there. So I've moved the thyroid gland a little bit to the right and the left, and then allow it to move up and down as he's swallowing.